Welcome, everyone. Thank you so much for joining us today for this educational patient webinar. The topic today is Understanding Heart Valve Disease, What You Need to Know. I am pleased to be joined by Dr. Charles Peniston, cardiovascular surgeon, and Brian Sakransky, a heart valve disease patient. I'm Ellen Ross, and I'm the Managing Director of Heart Valve Voice Canada, and I'll be moderating the session today. In today's webinar, you will get a better understanding of what heart valve disease is, including the signs and symptoms to watch out for. You will also learn about the most common treatment options available to you and what to expect if you do need heart valve intervention. Just to introduce Heart Valve Voice Canada, we are a nonprofit organization whose mission is to educate and advocate for early detection and diagnosis, along with innovations in treatment, so that all Canadians with heart valve disease get the best possible care over their entire patient journey. I do encourage you to find us online at heartvalvevoice.ca to find out more about our webinar series, to sign up to receive our monthly newsletter, or access many of our patient resources. And now it is my pleasure to introduce today's presenter, Dr. Charles Peniston. Dr. Peniston is a cardiovascular surgeon at South Lake Regional Centre in Newmarket, Ontario. Prior to that, he was a staff surgeon and assistant professor of surgery at Toronto General Hospital and University of Toronto. Dr. Peniston works with adults in need of heart surgery or TAVI procedures. He also is the chair of the board of Heart Valve Voice Canada. Dr. Peniston, thank you so much for taking the time out of your busy schedule to talk to us today about heart valve disease.
Thank you very much. It's my pleasure to be here and to participate in this webinar with my colleagues and friends. Heart valve disease is a title given to abnormalities of one or more of the main valves of the heart. So just to step back for a second, why do valves exist? Well, they exist so that blood will flow normally throughout the body. So the heart beats, it applies energy to the blood. And the reason that blood flows forward is because there is a series of one-way valves inside the heart. And essentially, one can imagine the heart as having two parallel circulations, one that receives blood from the body and pumps it out to the lungs, and another that receives blood from the lungs and pumps the blood out to the body. So essentially, each ventricle, that is the chamber of the heart that pumps the blood out to wherever it's going, has an inlet and an outlet valve. So on this, what we call the right side of the heart, that is the part of the heart that receives blood from the body, the inlet valve is the tricuspid valve, and the outlet valve is the pulmonary valve. On the left side, and this is the part of the heart that pumps blood out to the body, the inlet is the mitral valve, and the outlet valve is the aortic valve. And just to point out one major anatomical difference between the valves is that the aortic and pulmonary valves, the outlet valves, are part of the main artery coming out of the whichever chamber, whereas the inlet valves, that is the tricuspid and mitral valves, have strings attached, which you can see here, that go down to the walls of the appropriate ventricle. And these strings provide support to the valve so that they don't, so the leaflets don't pop back up into the receiving chamber, the atrium. Next slide, please. So naturally, we're born with valves that work properly, or most of us are at least. But over time, valves may become diseased. And this may result in either narrowing of the valve, which in medical speak is called stenosis, or the valve may leak, which is called regurgitation. Or there may be both combination of, in one valve, a combination of stenosis and regurgitation. And of course, as you can imagine, the severity of this process can be described as mild, moderate, severe, or critical, and depends on various measurements that we use that can be gained from diagnostic tests to determine the severity of the disease of the valve. So what happens with the stenotic valve is that it becomes scarred and often becomes calcified as well. And essentially, bone is being laid down on the valve leaflets, or the surrounding structures may become calcified, and this is more typical of the mitral valve, and the calcium can encroach upon the leaflets of the valve. Regardless, as a valve becomes scarred or fibrotic and calcified, its mobility decreases and the valve becomes stiff, and it's harder to open the valve, and the opening becomes narrow. The consequence is that the heart has to work a lot harder in order to pump the same degree of blood or amount of blood out to the body. Whereas if a valve becomes leaky or regurgitant, the heart has to work harder, but in a different way. Because as the valve leaks, blood is either flowing back into the left ventricle, if it's the aortic valve that is leaking, or the blood is flowing up to the left atrium, if the mitral valve is leaking. And so, but there's still blood flowing forward as well. Regardless, the heart has to do considerably more work than before. There's another condition called mitral valve prolapse. And in this situation, the leaflets or flaps of the valve bulge upward into the left atrium. And this is because there's growth of tissue in the mitral valve flaps themselves, such that they become elongated. And also the cords that attach the leaflets to the wall of the left ventricle can become elongated. It doesn't mean that the valve will necessarily leak, but it clearly predisposes to subsequent abnormalities of the valve where in fact it does leak, or the supporting cords break, and then part of the valve prolapses way up into the left atrium and can't meet its counterpart on the opposite side, subsequent that there's significant leaking of blood into the left atrium. We classify heart valve disease as congenital, in other words, one is born with it, or acquired. And the acquired disease can become through just aging, degeneration of the working parts of the heart. So just as we get older, we may get stiffer joints, or we can't run as fast as we want to or as far as we could, or our lungs don't work as well. The heart can start to wear out as well, specifically the valve, just from natural wear and tear. On the other hand, we can run into trouble from infections of the heart valves, about which you'll hear more soon. And essentially what can happen is that the valve tissue becomes destroyed by the infection. Also, we can have leaky valves because of disease processes occurring in some of the supporting structures. For instance, the aortic valve may become leaky, not because there's anything wrong with the leaflets per se, but because the aorta itself becomes very dilated at its root where the leaflets attach, and it pulls the leaflets apart, causing the valve itself to leak. Or with the mitral valve, the heart may enlarge, either because of some process occurring with the heart itself, or after a heart attack, the heart enlarges, it changes the geometry of the cords that support the leaflets, and again, the leaflets can't meet and they become leaky. Next slide, please. We know that there are certain risk factors for the development of aortic stenosis, remembering that aortic stenosis is narrowing of the aortic valve. So as I mentioned in the previous slide, age is one risk factor. And we know that for patients over 75, at least 3%, if not more, will have aortic stenosis. Radiation to the chest for breast cancer, for treatment of lymphoma or other tumors in the chest is a risk factor for developing aortic stenosis. Likewise, diabetes, high blood pressure, high cholesterol in the blood, and smoking are also risk factors. About 1% of the population has a slightly abnormal valve in that rather than having 3 cusps to the aortic valve, there are only 2. And this is because 2 of them are fused together. And while these valves may be really quite narrow at birth, that's relatively unusual. But over time, there is abnormal wear and tear of the bicuspid valve such that it may either dilate out or typically becomes narrow, sometimes with leaky as well. And the valve becomes very narrow such that by the time the patients hit their 50s or 60s, they have severe narrowing of the valve and require some form of intervention. Next slide, please.
Dr. Peniston, there are many myths about heart valve disease, and it would really be great if you could shed some light on them. For instance, some people believe heart valve disease only affects older people. Is that true?
No. As I mentioned before, some people are born with quite severe valvular disease at birth, although I must admit this is pretty rare. On the other hand, there is that patient group who have bicuspid aortic valves, and these cause certainly predisposed to premature valvular disease. There is a group of patients that have aortic disease that causes aortic valve to leak, and there's mitral valve prolapse, which is not exactly a genetic disease, but nonetheless, mitral valve prolapse can occur at a younger age and predisposed to early mitral regurgitation.
You also hear people mention that they have heart murmurs. Are all heart murmurs the same?
No. And let's go back. This is an interesting point. What exactly is a heart murmur? So a murmur is something that is detected by someone using a stethoscope and listening to the chest. So typically one can hear the heart sounds, which are usually they're classified as 2, although technically there are 4. It's harder to hear the 3rd and 4th ones. But and everybody's familiar with lub-dub, lub-dub, and nothing in between. Whereas a murmur is hearing a sound between those heart sounds. And they indicate that there's maybe some abnormal flow across the valves. So if one thinks of water flowing down a river, you look at a large, broad river, the water is flowing smoothly, you don't hear anything. But as that water cascades over rocks and et cetera, and fallen trees, et cetera, in a river, and there's noise. And the reason you hear noise is because there's turbulent flow, there's acceleration and deceleration. And that's what's happening as blood flows over these abnormal valves. And so that's what is heard as the murmur. So an innocent murmur might be one that is detected, especially in a younger patient with a very healthy heart. And it's called a flow murmur. And typically it's across the pulmonic valve. It does not indicate any disease or illness whatsoever. On the other hand, as valves become narrow or leaky, then these are abnormal murmurs. It doesn't necessarily imply that there's disease or something needs to be done, but it clearly indicates that the valves are not perfectly normal.
That's great. Thanks for clarifying. The other question that often comes up is, does an unhealthy lifestyle like poor eating habits cause heart valve disease?
Not in exactly of themselves, but we know that unhealthy lifestyle predisposes to coronary disease, which could cause heart attack and subsequent mitral valve regurgitation. And we also know the same risk factors for coronary disease and the ones you're outlining, like poor nutrition, smoking, diabetes, etc., are the same risk factors for developing aortic stenosis.
Great. Thanks for clarifying that. The other thing you hear is that you can't tell if you have heart valve disease. Is that true?
Well, there clearly is a large segment of the population that has no symptoms. And even remarkably, there's some patients who have really bad valve disease who have no symptoms. I'm always astounded. That's not a huge segment of the population, but nevertheless, they exist. But we do know that some early signs can be detected. And we'll get into that in a little more detail shortly, but basically there are signs of fatigue or breathlessness that you just may not be aware there, or they're quite subtle, or maybe a bit of swelling of the ankles. So there is, and some, frankly, some leaky valves take a long time to become symptomatic. And in fact, we operate on those patients before they become symptomatic because, and this applies specifically to aortic regurgitation and mitral regurgitation, where the valve can be repaired or for aortic replaced as need be. But regardless, we know it's better to do that before symptoms develop, because otherwise too much damage can occur to the heart and there's not return to normal heart function. But again, this is the importance of listening to the chest and listening for murmurs specifically, amongst other things, and then investigating as need be.
So another myth is with regards to treatment. So you've talked about detection. Do people that have been diagnosed with heart valve disease need to wait a long time before they get treated?
Well, like everything else, it depends. So we do essentially triage patients to some extent based on the severity of the disease. There's no doubt that anybody who needs urgent or emergent surgery will obtain it with as soon as possible. But other people, frankly, don't need surgery right away or intervention right away. And it's probably better for them. And these obviously would be more on the categories of mild or moderate disease, where it's safer to follow the patients rather than to jump in and correct something. The risks of procedures are low, but the natural history of the disease may show that there's a long sort of interval time or development time or maturation time for the disease process to become severe enough that it warrants intervention. But there's no doubt, and I want to emphasize this, that if someone needs urgent or emergent intervention, that it will take place, especially, and this is times of COVID, that people should not hesitate to seek advice, COVID or no COVID.
Great, thanks for providing clarity around all those myths.
It's really important for patients, in order for patients to make a full recovery, to seek medical help if they develop symptoms. So I kind of alluded to this earlier, but early detection and diagnosis are really important to getting back to the full recovery and its full heart function as is possible. So where sometimes we just think that we're getting older, or just, you can imagine what people might think to themselves. I just don't have the same energy as I used to, or, I just might get up and go, got up and went type of thing, or, things that you just think are just part of normal aging aren't necessarily so. And if one does note that there's a decrease in exercise tolerance or easy fatigability or shortness of breath, and admittedly, these sometimes are rather non-specific symptoms, but regardless, it is important to check them out, because by so doing, one can get on the route of investigation, and then the investigation may say that, there's nothing wrong with your heart, or there's something wrong, but we don't need to do anything, or lastly, there's something wrong, and we really should do something before something serious happens to you. So early detection and diagnosis really is very, very important. The signs and symptoms, and just to go back a second here, symptoms are what patients experience. Signs are what one may see when looking at someone's body or listening, etc. So the symptoms of heart valve disease include, and they're not only these symptoms, but by far these are the most major ones and common ones, or shortness of breath on exertion. So whereas one may have noted before that you could easily go for a walk on the street or climb a hill easily or stairs, then as the patient develops valve disease, that in fact they can't do these activities as easily. They become out of breath, or they tire or fatigue easily, or they climb stairs and they have to stop and catch their breath. They're panting. Or if it really gets bad, then they find they become out of breath even with really simple activities such as making the bed or getting dressed, brushing a hair, having a shower type of thing. Less common and really we're talking here about left-sided valve disease, that is aortic valve disease and mitral valve disease, these being the most common. Less common symptom is chest tightness or pain, typically referred to as angina. And the symptom is really more of tightness as opposed to pain. And it's a sense of tightness, as mentioned, or a squeezing or a heaviness in the chest. And it tends to be rather vague. It's fun. It's the brain's funny way of trying to externalize internal symptoms. Our brain isn't designed to localize in great detail where internal organ dysfunction is occurring, as opposed to burning your finger with a match, which is pretty obvious. I mentioned fatigue and exercise tolerance. Another common symptom is lightheadedness or dizziness, typically with exertion. And this probably relates to decreased output of blood by the heart as in a sense of a time of demand. So just the body can't initially for a brief period make a adjustment in blood pressure and delivery of blood to the head. And so there's these sensations of lightheadedness or dizziness may appear. They're usually short acting. Occasionally people do faint. I have to say that fainting may be a bit non-specific because it could also be related to many other situations occurring, and specifically with the heart, at least, it could be related to an abnormal heart rhythm. Swollen ankles is a sign of, or at least can be a sign of heart disease. There are other situations that may cause swollen ankles, liver, kidney disease, lymph disease, etc. But it's pretty common in patients who are developing heart failure and also right-sided heart valve disease, and specifically tricuspid valve regurgitation. Difficulty breathing while lying down relates to abnormal fluid distribution in the lungs as the patient goes from being upright to being supine or lying on your back or prone. Not many people sleep in a prone situation. Anyway, what happens is that blood starts to build up into the walls of the lungs, and the lung becomes stiff. It becomes harder to breathe. And so the patient may try and alleviate this, and usually successfully, by keeping the head of the bed up. And this often works very well. Sometimes patients wake up in the middle of the night gasping for air because they've been able to sleep through the initial parts, and then suddenly it's just so hard to breathe that they're breathing very deeply and rapidly. And it resolves within a few minutes while being upright. And then it's not rare for these patients to spend the rest of the night sleeping in a chair. Palpitations, or the sensation of an abnormal heart rhythm or beating, is common. It's not exactly related to the valve disease itself, but to sort of downstream effects as sometimes the atria, that is the upper chambers of the heart, enlarge with valve disease and become prone to irregular flow of the heart signal through these chambers, and sometimes it becomes disorganized such that there really is just chaos there, and so the heart beats irregularly and rather rapidly. Finally, coughing can be a symptom as well. This is pretty non-specific, to be honest, but it's not rare for patients to present to the hospital with some degree of heart failure and coughing, but this may, and frankly frequently is, I don't want to say misdiagnosed, but is treated as pneumonia because it's not clear on the chest x-ray what the primary problem is, in that patients who have heart failure can get pneumonia and vice versa. Pneumonia can predispose to heart failure, and often patients are treated for both when they go to the hospital. So the net effect of this is that it really is important to seek medical care if the patient develops any one of these signs or symptoms. The way that heart valve disease is diagnosed is typically initially with a history and a physical examination. And the examination will consist of listening to the heart and lungs. And the way we listen to the heart is with a stethoscope, and that's being used to listen for the heart sounds. So the lub-dub, as I mentioned before, and whether they're loud. Sometimes those sounds may actually disappear. And doesn't mean you're not on death's bed if they disappear. It's just because the way the valves are working, or the detection of a murmur. Far more accurate is to do an echocardiogram, and this uses sound waves a bit, and the echo part is because the sound waves bounce off the structures of the heart to create an image, and also the sound waves can look at the flow of blood through the heart, whether it's normal or abnormal. And by examining the flow of blood, one can determine severity of valve disease, as well as looking at the actual structure abnormalities of the valve. Lastly, an electrocardiogram is done, not that it makes a valve diagnosis so much, but it's really important to know the rhythm of the heart, as this can help decide various forms of treatment. I'd like to introduce Mr. Brian Sukransky, and he will tell you a bit about himself shortly. But he's been a board member of Heart Valve Voice Canada and has made very important contributions to our organization. And more importantly, he's a person who was born with valve disease, as he'll say, but he can give you a personal outlook as to what it's like to have this, and then to run into some pretty serious complications related to this problem. Over to you, Brian.
Thank you, Dr. Peniston. Hi, everyone. As Dr. Peniston mentioned, I'm Brian Sukransky, and I'm a heart valve disease patient. I'm going to focus on three of the most important aspects of my story. So first, my story starts way back when I was a teenager. My family doctor noticed a murmur and referred me to a cardiologist. And by the way, note, this was done with a basic stethoscope exam. You're going to hear about the stethoscope exam over and over again throughout this webinar because it's so important. The cardiologist that I was referred to determined that I had mitral valve prolapse, a condition that I was born with. I didn't have to see a cardiologist again after this initial assessment. There was no specific monitoring, and having mitral valve prolapse did not impact my life at all. The only thing I remember is that for some time, I had to take antibiotics before a dentist appointment. But actually, the guidelines changed, and then I no longer needed to even do that. So living with mitral valve prolapse was really easy for me. That was until 2014. When I was diagnosed at that point with infective endocarditis, which is a rare and highly lethal infection of a heart valve. However, before that diagnosis, I had initially been misdiagnosed 4 times over the course of several days and watched my health rapidly deteriorate. My symptoms presented like those that Dr. Peniston spoke about earlier. I had dizziness, I had a fever, I had fatigue in particular. I also had one additional symptom that Dr. Peniston did not mention, which was shivers, or I would call it or refer to it even as shakes. I had violent shakes at night, in particular when I was trying to go to bed, and I felt cold all the time. So a big part of the reason I was misdiagnosed was because my symptoms presented similar to many other diseases. Doctors diagnosed me with the flu, then a virus, and finally they thought I had viral meningitis. My wife, who is a doctor, luckily, thankfully, believed it was important to evaluate how being born with mitral valve prolapse was playing a role in my declining health. So I finally received the proper diagnosis after my wife advocated for an echocardiogram of my heart. But unfortunately, by that time, I was in full heart failure, which caused me to slip into a coma. And I was put, at that point, I was put on a ventilator and hospitalized for many, many long weeks. As I mentioned, I never had experienced any symptoms or issues related to mitral valve prolapse prior to getting this infection. It had been completely benign. Afterwards, I had to wait about a year to recover from the infection, and also for the surgeon to be certain what type of surgery I needed. There was a significant amount of uncertainty about whether a valve repair was possible or if I needed a complete heart valve replacement. So heart valve surgery eventually became a viable option, and that's the treatment option I pursued. After open heart surgery, I had a quick recovery and was only in the hospital for a couple of days, but it took many weeks for my chest to fully heal. But afterwards, I was back at work in about 7 weeks post-operation. I have also continued my previously active lifestyle after my surgery. And though my cardiologist recommended that I don't run a marathon like I had always planned to, I continue to exercise, golf, ski, curl, and participate in many of the activities I used to do. So I think there's two key takeaways that I want to leave you with from what happened to me. And the first is to note that I was in my 40s when I got infective endocarditis. Many people think heart valve disease is something that only happens to seniors. That's simply not true, as my case proves. The second key takeaway is that I'm really grateful that I live in Canada and that I'm alive now in this day and age. If, for example, I lived in Africa or I was born 50 years earlier, I probably wouldn't be here today. There's still room for improvement, but in general, Canada is a good place to be if you have heart valve disease. We have a good medical system with access to the latest medications and world-class surgeons. Let's now move on to talk about the importance of monitoring. One of the key lessons from my story is that if you have symptoms, if you are not feeling well, just go. Just go to the hospital or just go to your physician. And when you are there, make sure that you get a stethoscope check. If you have heart valve disease or you were born with a heart valve problem, or if you are at high risk for heart valve disease, you should be tracking your symptoms over time. This will help you identify any changes in your health early. As Dr. Peniston mentioned, and my own personal story shows, early detection is key. If my endocarditis was detected earlier, it could have been treated with antibiotics. But because it was diagnosed so late, it had done significant damage to my heart valve and necessitated open heart surgery and valve repair. So I encourage you to visit the Heart Valve Voice Canada website and download our handy symptom tracker, and that will make your monitoring easier. I'm now going to turn it back over to Dr. Peniston.
Thank you, Brian. You've given us a very illuminating story of how heart valve disease can be asymptomatic, difficult to diagnose, and then suddenly cause a very serious situation that requires major intervention. And the other thing you point out is, and one of the causes of heart valve disease is infection. So there's certain situations that predispose to infection. And as you mentioned, you used to take antibiotics, so although the indications for those on a prophylactic basis have changed quite a bit in the past decade. Regardless, infection can arise out of the blue and cause destruction of the valve leaflets. Hopefully they can, I mean, not all infections do this, to be clear, but there are some particularly virulent organisms that can essentially destroy the leaflets, cause valve leakage or regurgitation, heart failure, and necessitate heart surgery. There are different ways to treat heart valve disease, and they really, you can kind of categorize them in the following way. So one is, actually, if you just go back for a bit, that would be, because this is, I just want to be more broad here for a minute. Thank you. One is to just watch and wait. And this is because although there's some abnormality of the valve, it isn't really severe enough to require any investigation. And but on the other hand, should be followed on a usually on an annual basis by the patient's cardiologist, and this will usually include physical examination, and an echocardiogram, maybe some stress testing, possibly some other investigations. And this may just be a watch and wait forever, because not all patients with heart valve disease need intervention. Sometimes there might be a situation where there's mild disease, but there might be in combination with some other situation that requires medications. And this can be very effective for a while as well. But as the condition deteriorates or increases in severity, then some kind of intervention may be required, which could either be surgical, in other words, with an operation, or done through catheters that are inserted through the veins or the arteries of the body. Could you go to the next slide, please? Thank you. So one treatment option to fix a valve is with surgery, and it's possible to either repair or replace the valve depending on the valve and depending on the nature of the disease affecting the valve. I won't get into the technical aspects of repairing valves or replacing them for that matter, but the advantage of this approach is that there's definitive repair or replacement of the valve. In other words, the job is done. Results are excellent, and subsequently patients generally have an improved sense of well-being and life expectancy. In other words, if someone has aortic stenosis at age 70 and has symptoms, we know that that patient's life expectancy will be increased by having surgery, and presumably TAVI as well. We just don't have enough data on that yet, as opposed to just leaving the valve alone. Likewise, if someone has mitral regurgitation, even that's asymptomatic at a young age, and if the valve can be repaired, that patient will have improved life expectancy compared to just treating the valve, just watching the valve. This assumes all other things being equal, of course. Another advantage of surgery is that multiple procedures can be combined. By this, I mean that if a patient needs bypass surgery or a second valve to be repaired or replaced, or replacement of the aorta, it can be done at the same time as the primary procedure, whatever that may be. The obvious disadvantage of an operation is that it requires an operation. And while we have listed here that the risks are usually low, we have to understand too that if a surgery is indicated or an operation is indicated or an intervention is indicated, then to not do something also has risks associated with it. Nonetheless, surgery does require a recovery period, and you heard Brian say that it takes several weeks. It's not It's not instant recovery. And I always tell my patients that it could be 2 to 3 months. And for some, it could be even quite a bit longer, depending if they show up in a relatively debilitated situation. Another aspect of surgery is that there's a risk of an abnormal heart rhythm called atrial fibrillation. So this is not a dangerous rhythm, but it's a situation where the heart beats quickly and irregularly. It almost always occurs while the patient's in hospital recovering from the operation, and is usually easily controlled with medications that can be discontinued a few months down the road. Lastly, as I said a couple of minutes ago, after surgery, recovery takes about 2 to 3 months for the patient to feel pretty much back to normal. Next slide, please. An intervention specific to the aortic valve that does not require surgery is called TAVI, T-A-V-I, as you can see here on this slide. And you can see it stands for transcatheter aortic valve implantation. So briefly, this is a process whereby a new valve that is mounted on a delivery delivery catheter, and you can see on the slide on the far right side that there's a tube, which is the catheter, and on it is a new valve, looks like that mesh work in the upper arrow, which is crimped down or squished down on top of a balloon, or alternatively, the valve itself is tightened into a delivery system, and as the delivery system is released, the valve naturally opens itself up. It's a self-expanding valve. Anyway, these valves usually introduced through the main artery in the groin, the femoral artery, and advanced up with X-ray control or fluoroscopy in the cath lab and positioned inside the native aortic valve. And then the valve is either released for a self-expanding valve or is inflated with a balloon expandable valve. And what happens is that the native valve is pushed aside, and at the same time, the new valve opens up and takes the place of the old valve. But now there's a much wider opening or orifice for blood to flow through. And at the same time, the new valve is competent. By that, I mean that it doesn't leak. Now, there may be a little bit of leak between the old and new valve, but this seems to be of no consequence as long as it's mild or less. The advantage of this, of course, is it does not require surgery. And so recovery time in hospital is a lot shorter. It's only about 1 or 2 days, usually. And and the recovery at home is a lot faster too than would be after surgery. We know that, the results with this procedure are excellent. So there have been multiple trials looking at this procedure in high-risk patients, intermediate risk, and low-risk patients, and then sort of off-the-chart patients who would never even qualify for surgery. And we know that the results are very, very good with this. Another advantage of this is that it's a requirement for anybody who is going to receive a TAVI procedure that the patient be reviewed by what's called a heart team, consisting of cardiologists, interventional cardiologists, and heart surgeons. So in other words, you get the benefit of multiple team members participating in making the recommendation as to what should be done. Now, the result may be that after consideration, the heart team may suggest aortic valve surgery, but it may certainly be a TAVI procedure. Some of the downsides of TAVI are that we don't know how long they're going to last, because they haven't been around long enough for that data to become available. Whereas aortic valve replacement with surgery is a long-standing procedure. And there is a risk of new conduction abnormalities. And by what I mean by that is that if you look at the electrocardiogram, that there's this change in the pattern of conduction through the heart that usually resolves. Sometimes people need pacemakers though, because the signal doesn't conduct through the heart, and it just remains to be seen what will happen with these patients. Most new conduction abnormalities, in other words, left bundle branch which is a technical term, that often resolves. But we always follow these patients carefully to make sure that it doesn't progress to more major conduction abnormalities requiring a pacemaker. Generally, full recovery after a TAVI procedure takes place within 2 to 4 weeks, and we always follow our patients at 1 month intervals or at least the initial 1 month, to see how patients are. And I'm always amazed at how well they're doing. Next slide, please. A really interesting device is called the MitraClip. And this is a procedure done for patients who are too ill to undergo mitral valve surgery. It's done for a specific form of mitral regurgitation. And it really consists of running a tube up through the femoral vein. So the big vein in the groin, but it's not the artery this time, it's the vein. And again, done in the cath lab with the patient asleep, just because it facilitates implantation. And then using echo that is in the esophagus, so transesophageal echocardiography, to visualize the device. Basically, this device is pushed over to the left atrium and across into the left ventricle and grasps both leaflets and then secures them together. So essentially now, instead of having one opening, there are two openings, but what's happened here is that it's being used to prevent prolapse of the abnormal leaflet by anchoring it to a normal leaflet. So this has been around for several years, maybe not 10 years, but quite a while. And we know that it can really improve symptoms and survival in certain situations. There really are specific anatomical indications for this. And likewise, there's anatomical reasons why this cannot be done, which I won't go into here. The advantage is, again, that there's a rapid recovery, and again, there's a full heart team participation. This is again a combination of interventional cardiologists and surgeons working together. The con really is that it's not applicable to all situations of leaky mitral valves. And this could be because of anatomical reasons, or it could be because by doing this procedure, in fact, the valve may become too small to be truly effective. Recovery is quick. Next slide, please. Balloon valvuloplasty is kind of a niche procedure, at least in and of it's done on its own. I will say that as part of TAVI procedures, we almost always do a balloon valvuloplasty first, but really the prime procedure in TAVI is the actual placement of the new TAVI valve inside the old aortic valve. However, on its own, balloon valvuloplasty occasionally is done, and it may be done in the situation of narrowing of the mitral valve or mitral stenosis, and rarely, but for aortic stenosis as well. And for the mitral valve, it's done in the situation where someone has developed narrowing of the valve, but not calcification of the valve, and not where there's leaking of the valve. So rheumatic mitral valve disease is caused by thickening and scarring of the leaflets. It's related to rheumatic disease is related to developing scarlet fever or strep throat, which these days are almost always treated with antibiotics, and so heart disease doesn't develop. But it was common many years ago, and certainly in poorer parts of the world, it's quite common. Nonetheless, we do see it occasionally, and if someone does have rheumatic mitral valve stenosis or narrowing, then a balloon valvuloplasty may well be the best treatment for the patient. And again, it's similar to the other procedures in that it's a full recovery and quick, and go home fast and feel better quickly. Again, there's heart team participation. For the aortic valve, balloon valvuloplasty is more like a temporary fix, because the problem is that the valve tends to narrow down relatively quickly, and also we can cause more leakage of the valve than was present prior to doing the balloon valvuloplasty. So the long-term outcomes really are poor. Sometimes it's just done when the patient is so sick that we do it to temporize and get the patient through the most severe part of their illness, and then consider something more with a better long-term result a month or two down the road. Next slide, please. If a valve needs to be replaced, there are two basic types of valves that can be used. Mechanical valves is one type, and biological valves are the other type. Mechanical valves are completely man-made. So there's a sewing ring, which looks like the white material here. We're looking on the left side of the slide. And then there's the actual valve itself, which is usually made of carbon. It's kind of cool stuff. Actually, it was what was used to coat the original space capsule so that they wouldn't overheat. Anyways, essentially pulverized carbon that settles onto a block, and then it's carved out. And in the middle are these leaflets that go back and forth passively, just as the leaflets on a normal valve move back and forth passively. Anyways, mounted onto a frame, and the valve itself is sewn into where the old valve would have lived. The thing about mechanical valves is that they last virtually forever. Occasionally, scarring can form underneath the valve. But because they're totally man-made, the body sees it as a foreign material and will try and form clots on the valve, which can interfere with the motion of the leaflets and cause them to become narrow or stuck, or the material could break off and cause a stroke. So it's easy enough to prevent all that from happening, but it can only be done by using a medication called warfarin, or the trade name is Coumadin, which has various issues associated with it, namely blood tests and careful considerations of diet and alcohol consumption, etc. The other main types of valves are biological valves. Again, there's a frame and a sewing ring shown in pink here on the right-hand side of the slide. And then the actual valve itself is made either from a valve that's been transplanted from a pig, so it's a real pig valve, or the membrane from the heart of a cow, which is called the pericardium, is sewn into and onto the frame. And again, they work just like a native valve. Occasionally, we use what are called homografts. So this is where the aortic root, so the aorta, the leaflets, the coronaries, and the base of the aorta are harvested is the word I guess used from a donor and frozen, and then at the time of use it's thawed out, of course, and then sewn in like a whole block of tissue into where the old aortic valve would have been. These are typically used for younger, like much younger patients, or in the pediatric world, occasionally in the setting of severe infection, or occasionally or generally for much younger patients. The problem with human tissue is that it calcifies quite heavily over time, and reintervention can be rather difficult. Anyway, the vast majority of biological valves are animal tissue, either the pig valve or the cow material. They're treated with a substance called glutaraldehyde so that the body doesn't react to it. In other words, there's no immune response. The valve will not be rejected. The advantage of tissue valves is that no blood thinners are required, as they are for mechanical valves. This downside, if such, is that it does have a limited durability, but it really depends on the age of the patient. So the older one patient becomes, the longer the valve will last. And realistically, in a sort of 60-year-old, you can expect 10, maybe 15 years out of the valve, and someone in their 70s can expect at least 10 to 15 and probably 20 years out of the valve. So they're essentially very long-lived. Next slide, please. Brian?
Thank you, Dr. Peniston. Let's move on to talk about post-treatment. In my particular situation, after my surgery, I see my cardiologist now once a year, and during each visit, I get an EKG. The other change or big change that's now happens post-surgery for me is that every time I go to the dentist, I have to take antibiotics. I'm used to doing that. I used to have to do that before, and then it stopped. But now, since I've had infective endocarditis, it's now, a requirement every time I go see the dentist. The other change is for quite a number of years, I was taking a daily baby aspirin, but actually I don't do that anymore. So, none of these changes are particularly onerous. I have modified my lifestyle slightly since having my surgery. I didn't have a bad diet before, to be honest. Getting endocarditis wasn't because of my lifestyle. It was just random bad luck. So nonetheless, I don't want to go through this again, because my understanding is that I do have a slightly elevated risk of recurrence of infective endocarditis. So I do try and eat a healthier diet, and I keep it simple. So a heart healthy diet, which consists of lots of fruits and vegetables. I try and limit my red meat intake, or to be more precise, my wife limits my red meat intake. I exercise on a regular basis, no heavy weights, however, but everything else is allowed and tolerated. So I mostly do cardio and, let's say, light to medium weightlifting. I watch my weight. I try to stay within the BMI guidelines for healthy body fat. And that's it. That's all I really do. No major radical changes, but some smart minor tweaks to my diet and exercise post-treatment. Back to you, Dr. Peniston.
So it's really great to hear how someone can undergo in treatment of a major infection and surgery and return to normal living. And I think that's a really important message for everyone to understand, that this is not some kind of death sentence, or that you're going to be left with some permanent disability. But rather that if all goes well, and the vast majority of time things do go well, that one really can return to a full and healthy and fulfilling life. As part of that and part of the recovery, it's really important for patients to consider rehab if possible. I will say that during the COVID pandemic that we're experiencing now, it's a bit difficult. Rehabilitation would normally is a program that's offered really to, we've listed here TAVI and SAVR patients, which refers to surgical aortic valve replacement. But cardiac rehab is really offered to anybody who's had some kind of significant cardiac intervention, because it promotes good cardiac health. And certainly, especially after surgery, where there's a recovery period, and during which time there may be significant metabolism and consumption of muscle mass, and part of the healing process, it's important to have a controlled but supervised rehab program, which is essentially, it's not just an exercise program, although that's part of it, but there's an education program, there's teaching, there's monitoring, and there's also a certain social aspect to it as well. In other words, of being with other patients who come in different stages of heart disease. But anyway, there's something about working together that helps people recover after heart valve intervention. Next slide, please.
So I'm going to summarize now with some key takeaways. I hope my story is enlightening for people. In particular, I want to make sure that you understand how important early detection is, and how a simple stethoscope test is key. because a murmur or a leaky heart valve have very distinct sounds that a doctor can usually pick up on. So I encourage you to ask your doctor to perform a stethoscope test on a regular basis. At a minimum, it should always be done during your annual physical. The other big takeaway I want to remind you of is that you need to advocate for yourself. Now, I want to be clear that I'm not saying this in a negative way in the sense that the medical community does not care about you, but doctors are very busy and many different diseases present with the same symptoms. For example, shortness of breath and dizziness can be symptoms of literally hundreds of different ailments other than heart valve disease. So doctors don't know how you usually feel or how your breathing has changed from last week, for example. But you know your body better than anyone else. So in my case, I was born with mitral valve prolapse. The doctors I saw when my infective endocarditis occurred did not know this. So this is why you need to advocate for yourself. Now I'm going to turn it back over to Ellen.
I would just like to say thank you so much to Dr. Peniston and Brian for providing everyone with a much better understanding of heart valve disease and for sharing your story. I'd also really like to thank our supporters, Edward Life Sciences, Every Heartbeat Matters, and Boston Scientific, who really make all of our work possible.